What if the secret to postmenopausal health and energy was not about reversing time, but working smarter with your biology? Today on WellWaveNOW, we are joined by Dr. Josie Tenore to explore how women can thrive after menopause, not just survive. Welcome to WellWaveNOW, your portal for actionable wellness insights. We, Rick Rice, Dr. Bob Levine, and myself, Tim Daniels, are your wellness catalysts committed to elevating your health, enhancing your functionality, and optimizing your performance at every life stage. WellWaveNOW, where timeless wisdom lights your wellness path. Dr. Josie Tenore is a board-certified physician, has a Master of Science in Public Health from Harvard University, and also has advanced training in sports medicine, hormone optimization, aesthetic medicine, and longevity sciences. She brings all of this together at her work and through her work at Trevi Health, where she helps patients achieve vitality and better health spans, not just lifespans, using science-backed and deeply personalized approaches.
So welcome back, Dr. Josie. It's so great to have you on the show again. I sure thoroughly enjoyed our conversation with you last time. So how have you been?
Right. It's fun. It's starting to finally warm up in Chicago, so that's exciting.
That is exciting. Well, thank you so much for being our guest today, and we look forward to jumping into this so important topic. And here's a statistic that surprised me. I didn't realize that most women still live on average about 30 more years after menopause. And so that's, 3 decades, right, of life. Yet too often those years are treated like kind of an afterthought, a biological afterthought. And I think that there's a lot more to life, right? You can experience and still have a lot of good things if we know what we need to know. And that's why I'm so excited to have this conversation with you today. So let's hop into some of the topics here, and just give us a quick overview of this work this so important work that you're doing, Dr. Josie.
So, one of the things that I do in my practice is I do have a focus on women's health and hormone health for many reasons. Having gone through menopause myself, I won't say how long ago. And I was looking for a hormone provider. And I have to be honest, I was shocked at the time because I went, hoping that I would find somebody who would treat me with bioidentical hormones. And after being lectured to negatively by numerous physicians, I'm like, oh my God, how do people not know the science? And so I embraced the topic because I thought it was very important. My mother's 93. So 3 decades, I'm looking at, 4 decades after menopause or longer. And there's no way that I just wanted to shrivel up and, melt away. So it's
So,
very near and dear to me.
so along those lines, what are Bob's shriveling up, so the rest of us don't mind it, so that's okay. But with those, what are those kind of changes that you anticipated or were aware of, or that your patients are aware of, that kind of led you to say to the fact to look into the hormone replacement in the first place? And so, what are those physical, psychological, neurological, physical, and any other changes that come about that people are facing?
So generally, what tends to happen with, the transition, although hormones start to decline for women, something like, well, testosterone in the mid-20s start to decline. But as we get older and in the perimenopause in particular, so this is like 10 years before menstruation stops. So the term peri just means around. And what starts to happen is there's, fluctuations in hormones. And then with menopause, it's this a drop. But with those fluctuations, there's this development of like truncal, yeah, this round tire around the middle. So fat becomes redistributed on the body. And there is this sense like you go to the gym and it's like, how come these muscles are a little saggy and you just don't feel the same recovery? You start noticing that, you're sort of fatigued. Sleep. Oh my God, sleep becomes really interrupted. So there's, and with sleep, sometimes it's sleep interruption, but also this sense of like you go into a room and I'm like, I know why I'm here, but I have no idea. So just having this brain fog, like people talk about brain fog, and unless you've experienced it, you can't really understand it. But it's just this lack of clarity that happens when you lose hormones. And so, with all of this, it just does seriously impact the quality of life day to day.
And how do these changes affect women long term? what are some of the risks if you don't take the hormone replacement or really focus on your nutrition?
Well, hormones aren't for everybody, so we'll start with that because there are people who transition, and I have my own theory on why that is, having done a lot of labs. But what happens, estrogen in particular, is very, very protective to the vasculature. So it's also protects somebody from insulin resistance, so metabolically. And when you lose estrogen levels, that protection on blood vessels declines. And it's true for men too. Back in the day, I used to block estrogen when I did testosterone replay. I don't do that anymore because it's, unless men are developing breasts, I want that estrogen there because it's very protective to the vessels, which then translates to being very protective to the heart, the brain, and every other organ. So if you, depending on the family history, it can be disastrous for some people not to take action early to protect their brain and to protect their heart from these changes.
So what are some of those risks then? So you talked about both brain and wrist. So full-blown cardiovascular problems, heart attack. What exactly when you're talking about cardiovascular health?
Before menopause, women rarely have heart disease. The number one cause of death for women postmenopausally is heart disease. And this is like one of those things where everyone's like, it's breast cancer. No, it's heart disease. So if, just because you may know somebody with breast cancer, because everyone seems to know somebody, that's sort of the fear. But really, the heart is much more of a vulnerable organ. And it is pretty shocking that until recently, there was this lack of understanding that it was also protected the brain. We did know that estrogen protects bones, so you have bone strength. We knew it protected the gut. We had this sense that maybe it did protect the heart, but the risks outweighed the benefits. But it's actually not true. And so, yes, women, unfortunately, the statistic for women is that they die of their heart attacks much more readily because their symptoms are so nonspecific. They don't get chest pain or pain in the jaw. They get fatigue.
Mm-hmm.
And it's, so the risks are real, and the cardio protection and the neuroprotection is real as well.
So I'm glad you re-mentioned neuro, because that was my next question. Now, what are the risks for the brain? Is it Alzheimer's? Is it something else?
So that's the problem, is we don't have a lot of very good studies that have used current medications that we use now and following women. But recently, what was very exciting is I saw a presentation by a neurologist who her field of work was MS. And she sort of made this observation, wow, during pregnancy, women's MS goes into remission. And postmenopausally, it's disastrous. Their effective, their illness is rapidly declining. And so she started looking at what is the protective factor. And guess what? It's estradiol and estriol. So it is absolutely protective to the brain. And if the coverings of the brain are that vulnerable, there is the belief that dementia could be improved with estrogen replacement. I mean, I actually have a personal story with an ex-boyfriend's mom who was, she was on Prempro. So these were not modern day medications. For years, she moved back to Canada, and at 75 years of age, because of family. And she had been playing 5 hours of tennis every single day for years. Well, her doctor in Canada flipped out. What's a 75-year-old doing on Prempro? Stopped her medication. And within 1 year, she did not recognize her own child. Her dementia was so rapidly deteriorating. You cannot convince me that this wasn't because they stopped hormones. There was nothing else that changed.
We've got the cardiovascular risk. We've got the brain performance risk, brain health risk. You alluded to bones a little bit, and you used to estrogen as a perspective for bones. But so talk to me. I always hear about women taking vitamin D for it's calcium and some other things. So for the bone protection. So what's the interplay? What's the interplay there between everything, Dr. Josie?
Well, you need the hormones in order for the calcium and the copper and the vitamin D to stick. unless you have, it's kind of like having a door without a keyhole. And your key is your vitamins, and you've got your calcium, you've got your vitamin D, you have all these things and it's floating around, but your door is locked. You're not, how are you going to unlock your door? You don't have a keyhole. So the hormones allow these nutrients and minerals, because it's not just calcium and vitamin D, it's vitamin K and it's copper and a million other minerals. But these nutrients need someplace for the formation of the inner portion of the bone. So the bone marrow. So there's all sorts of drugs that create a thicker lining on the outside of the bone, but none of them will create bone marrow. And hormones allow the marrow to remain juicy and not without whole, like less holy than with what had develops with osteoporosis.
Okay. So now we were going to get into this part a little later, but I think it's appropriate now because we've mentioned hormones a lot of times. And I don't know if we want so some people might be thinking that's all to your approach and all that's needed for women to thrive post-menopause. Is that what you're saying? Is just give us more hormones and replace the hormones and everything will be fine? What are you saying, Dr. Josie?
No, I mean, hormones, yeah, I like to give analogies just because that's the way I educate my patients. But hormones are like giving you bricks to make a brick house. Now you got to do some labor. That house just doesn't get assembled on its own. You actually need to do things. So you can't, and I do have some patients who feel like, oh, I've got my hormones. Why is nothing happening? Well, are you working out? No. Have you changed your diet? No. Have you, have done some mindfulness? No. Okay. There's still an element of doing the work. However, when you have hormones on board, you're more likely to have the energy. You're more likely to sleep better. So therefore you can wake up and take on the day and do what it is that you need to do, make better nutrition choices. But, by no stretch of the imagination am I saying that hormones are the cure all and end all. There is a lot of work that still needs to be done. But it's just easier when you have hormone balance.
Okay. So given that, and given that you looked for some hormone therapy yourself as you got to this stage of life, and given these broad-ranging changes, why is hormone replacement therapy so controversial? And so what's going on there?
Okay, so this is like my pet peeve, but back in the early 2000s, there was a study that was conducted called the Women's Health Initiative. And I think it probably killed more women than it helped, to be honest. So it was funded by Heart and Stroke, believe it or not. And so they were following all these women for decades. So most of the study was not even what we consider in medicine to be the kinds of studies that we extract information and say, this causes that. They were prospective studies. They weren't randomized. But even with those, following.
Now I got to stop you for a second. You're treating me like Breck. Breck's always saying, Tim, you went to Stanford. And I told these guys a couple of times, the way I did that, I just was a janitor working in Stanford. And I just walked around the classrooms and I picked up different things and I looked at it and I pieced it all together. So you got to break this down for me. And now that I've come clean on that, you have to break it down for me when you say prospective test. What does that really mean?
So what it really means is they took women and they just did these reports and said, okay, were you on hormones? Were you not on hormones? And then they found out who had heart disease, who had bone, who had osteoporosis, who had breast cancer, and then they made associations. But then what they did was they took a bunch of women, 10 years postmenopausal, gave them oral hormones, which may not, now we know what not appropriate. A bunch of them died of heart attacks and strokes. The newspapers went crazy. Every menopause clinic across North America stopped. And to this day, even though there's very good, solid, positive information from that study, everybody thinks hormones cause cancer and testosterone's for men only. And so there's this fear that, or you're going to give me a stroke, you're going to give me a heart attack. So that's where the fear is. And because OBGYNs stopped being educated on menopause, a lot of women's health providers just don't know. And so they follow what the society guidelines are, and the guidelines are the least amount of hormone for the least amount of time.
So
And
when do you intervene then? So at what point do you know that it's appropriate to do something different like hormone replacement versus just allowing the body to naturally do its process?
patients who their body just goes naturally through the process, and they don't show up in my office, and they probably would not show up in anyone's office because, you know, I actually think they have low level hormones that because I see that. I see some of my patients, they come in for other wellness reasons, and I'm like, you still have some hormones on board. You still have some natural testosterone. So it's possible that there are those who just still have these low levels, and they transition just fine, and their genetics are such that they don't have heart disease in their family. They all live to 90. And so there's no reason to intervene. But for the most part, I intervene when people come in, and the most common reason that people show up in my office is they say, I went to my doctor, he did blood work, and he said, or she said, I was fine. And then I do blood work and I go, no, you're not.
Yeah, it's such a range, right? Because what is in the normal range for, me might be totally different from a superior athlete, D1, wrestling scholarship athlete like Tim. He was a scholarship athlete at Stanford, so don't let him give you maybe must not have been a full ride though, Tim, if you had to do some janitorial, right? So he was a D1 athlete there. But so what does that mean from one patient to the next to say you're in normal range? And I'm doing air quotes for those listening to the podcast, because everyone's different.
Correct. And so, interestingly enough, when I first started medical school, and I won't say how long ago that was, we talked about the normal range.
You're not going to tell. I'm not going to interrupt. You're not going to tell us how long ago that was, because you don't want all these women you're treating as post-menopause to realize how young you are, right, Dr. Josie?
No, I can tell you it's 40 years. So I've been a doctor for 40 years. So, it's been a long journey, which is why I remember the Women's Health Initiative. But so somewhere along the way, we stopped using the term normal range. It's now the reference range. And what's happened is the population has also gotten older. And so the reference range has dropped. So it is lower. So, when I talk to people, it's like, well, just because you're, certain hormones, we look at it and go, I mean, some are gone. Like, so it's like you have none. That's clear. There's no such thing as the reference range. But when it comes to other blood tests, it's, the interpretation is you're in the, like thyroid, you're in the low end of the reference range. That's kind of like you're functioning like a 90-year-old. Do you want to function like a 20-year-old or a 90-year-old? Pick one. So the reference range is intended to make sure that we're not seeing something that's so out of bounds that we're, okay, this is scary. There's something not good going on. Let's investigate. But the reference range, as you say, is very, very different. And patients, I tell patients that I use blood work to guide me, but I listen to their bodies to tell me the truth.
And along those lines, you look at it. So we have a question from the audience here. It says, and I'm going to paraphrase a little bit. When and if it is it too late to intervene at any point? So say someone's been in postmenopause for 10 years. Can you still step in and start? Is hormone therapy going to have an impact at that point, or is it too late?
Well, it depends on your endpoint and your goal. The data, unfortunately, is clear that if we wait more than 6 years to intervene, that estrogen is not cardioprotective. We can't prevent heart attacks and strokes. So there is that window that we want to intervene. That said, when you looked at the Women's Health Initiative data, if you looked at those women who were treated 10 years after menopause that didn't have a bad outcome, their risk of dying from all causes, so it's called all-cause mortality, was much lower in the intervention group than the non-intervention group. So I think that there's, yes, if you have a huge family history of heart disease, I always tell women, I can't, if you're more than six years out, I can't say I'm going to protect your heart, but I can give you quality of life. And I may be able to say that we can decrease your risk of dying from every other cause.
How solid is the data that after 6 years, it's no longer as effective? I mean, is there really good data showing that?
There's some, there was the ELITE study in 2020 and 2013. So there is some data that is suggestive, but they were using oral hormones. So, if you look at some of the information we have overseas where people's health is being monitored by the government because the government pays for their health care, you're going to get different information from that. But because we have a couple of studies that suggest we don't protect it, that's what I tell my patients, because I don't want to make promises that I can't keep. But, it is clear that the dying from all causes is much lower. So we're still improving the longevity and definitely improving health span. There's no question about that.
Right. And then you mentioned, so that's on the cardiovascular risk, if I remember correctly there. But then you alluded to the other part, though. It still doesn't mean that what about for the bone loss, for the brain performance, and for other things, that hormone replacement and other actions are still warranted, correct?
Yeah. I mean, I had someone whose daughter had sent her mom. She was in her 80s. And I'm like, okay, if this is, I have a conversation. We have as clear a conversation as possible. We put her on hormone replacement. She had a knee replacement and came back and said, wow, I recovered in 5 weeks. My last knee, when I wasn't on hormones, took me 6 months to recover. So, am I going to deny an 83-year-old the ability to recover faster from a knee replacement? Hell no. So there is, in my mind, if someone's coming asking, they have a willingness and an interest in having better quality of life. And it behooves me to provide that for them to the best of my ability.
See,
No, it's a different topic, Tim. It's a different topic, but I have to know what else was it just hormones that sped up that healing process, or were they doing something also? Were they using other modalities, PEMF or something else?
Not the only difference, because her daughter's a physical therapist. So she had good quality physical therapy, both knee replacements. Her diet was the same. There was nothing different. Now, can I say statistically and randomized? Yeah, I'm not going to tell you that. I'm just giving you an example of somebody who I treated later on in life, and she did experience faster recovery. And
wow.
I mean, to me, it makes sense. She probably was working out better because she had some testosterone to fuel her muscles. She was stronger going in, so that coming out of it, she could do her physical therapy more efficiently and effectively. I do think that she did her physical therapy. I mean, she didn't just recover with nothing, but the only line item that was different in her recovery was that she was on hormones with the second knee.
One other factor that was different. She already had one knee done. So she knew all about having the one knee done when she got her second knee done. So when people have the second knee done, it's always easier. I'm not saying this to refute what you're saying, because the difference between 6 months and 5 weeks is huge. So I just want to say there's another factor.
Although sometimes that factor is negative. They know what's coming and they put it off.
Mm-hmm.
Oh, I'm not talking about once they get it done, they know what the recovery is like.
Okay.
They have an idea about, that they've done it before. It's
Yeah,
like there's a big difference with women, the second pregnancy versus the first, right? Yeah.
Well, the first baby leaves instructions on how to get out.
And the mother is much more relaxed about it. It's likely to happen.
Yeah, fair enough. That is true, but it was a dramatic difference. It wasn't just
I agree.
like 4 days,
I just wanted to say that so that anybody listening would know that there are a lot of factors. I mean, so many factors is crazy. But anyway.
But you got to, I hear you, Bob. You got to clarify that a little bit. So what do you mean? So what do you think the impact of having the first knee replacement was on the second?
Oh, I think that Dr. Josie's telling us that it was a difference of 6 months versus 5 weeks, according to the patient. That's a huge difference. I mean, I don't see how anybody could, in my personal opinion, and I don't have any data on this, but it just, I can't imagine somebody would have that fast a recovery based on their prior experience. However, it's like I said with the pregnancy, a woman who's been pregnant the first time, it's a big difference from the second time. Second time is way easier, generally speaking, in the women that I've talked to and worked with. So, yeah.
So you think you get the second knee? the second knee should naturally have been easier than the first one, you're saying, Bob? Or
Absolutely. Absolutely. Yeah.
I would disagree. Having been operated on both my knees, I would disagree.
Well, I've been operated both my knees, so we're both anecdotes. I had the left one done and the right one done.
Why I disagree, because I hear you, it goes back to what Dr. Josie said. I think it's personalized, and it's just, I didn't want to go through in fact, I fought my second knee operation because I said I don't want to go through this again, and I'm just going to live without it. And then the doctor said, well, yeah, it might have been, you don't know how recent that injury was, so just go in and take a look at it. He found out it was an old injury, he couldn't do anything for it, and it was a much, and I had better rehab. So versus my old small town rehab that I went through facility, I had top notch college rehab. The same guy who helped. I'm having a senior moment now. I may need some hormones. Who's McEnroe? One of the same guys that supported McEnroe when he was there for a year was still a guy helping me recover from my knee thing, and it was worse. It took long.
That's why we call anecdotes are N equals one. It's one person, one story. That's why it's called an anecdote. That doesn't mean anecdotes aren't important. I think anecdotes are super important. In my case, I got an ACL reconstruction done on one day, and then 30 days later, I got the second one done. Second one was way easier for me. So I'm an anecdote.
Now you're an anecdote too.
Yeah,
so we're
exactly.
two anecdotes. We cancel each other out. But now I'm going to get. So I'll go back to fact. But I'm going to go back to one of Dr. Josie's points there. And Bob, you and Brett get to hear this from me again. You know how much I like to talk about my Moses plan. So,
okay, I need to know about Moses.
Well, you said the woman
just had Passover. So,
yeah. Woman came in, she was 80 years old and said, you thought about it. Well, Genesis 6:3 says, I will not let my spirit contend with man more than 120 years. So therefore, I'll take that to mean partially to mean that lifespan is about 120 years. And you go back, start looking biblically. It didn't happen right away at that point, but that's when it started trending down. They've had really tough time showing anybody living past 120 years now. But at 120, Moses could still climb the mountain. And in fact, he did still climb the mountain. He probably could have kept going, but God just said, that's enough. So it gets back to your health span and lifespan. To me, if somebody comes in at 80 and said, hey, I want to have some good more lifespan and I want to enjoy some health, give it to him like Moses. The Moses plan, make it that full 120, in a body you want to be in, functioning like you want to be, and climb the mountain the last day and say, I've had enough of Bob's anecdotes and Tim Dennis's anecdotes.
Hey, I got a 99-year-old client who's really quite vital. It's really impressive. And yeah.
Are they still climbing mountains?
No, they're not. I'm negotiating them to get off their walker.
Okay.
Yeah, working on getting off the walker.
Breck is a time for and Bob will get him off that walker.
Yep.
So Breck, is it time for one of your breaks with us?
Yeah, absolutely. I've got to ask, Dr. Bob, have you tried this yet? Or are you just so superiorly sharp that you don't need neurogum?
I can't hear you anymore, Breck. No, I need that. I need to try that. I do need to try it.
Yeah. So this half hour is brought to you by NeuroGum. I heard about this on the #1 podcast in the world, and so I thought, hey, if it's good,
I got to stop you just for a second. It's only #1 for another few months until we catch them, right?
Until we catch them, yeah. So hey, if it's good enough for that #1 show in the world, it's certainly good enough for the WellWaveNOW podcast. So with natural nootropics for energy and focus, natural caffeine. It has vitamin B12, vitamin B6, has the amino acid L-theanine. Also, that's known obviously for improving cognitive function as well. It's sugar-free, tastes great. So refresh your body and your mind with NeuroGum. We'll leave a link in the show notes for you and actually have a discount coupon for you if you're watching on TikTok. Thanks.
So, Dr. Josie, I was really impressed when you said hormones are not the only answer. It's not the magic bullet. And you talked about how it's important for people to eat right and get exercise and other things. And I'm wondering and I believe in that too. I believe that you got to look at everything. Have you ever seen clients who come in, they're just really buff. They've been working out, doing everything. They're postmenopausal and they're not hormoned up. And then you hormone them up and then they go back to doing more of what they did before. I'm sure you have tons of stories like that, but I'd like to hear a little bit about that.
Yeah, I mean, I do. And so, it comes to mind, like one health coach comes to mind because she, had questions during a Botox appointment. And so she was working out. She's obviously, she's a chef and a house coach, so she's been eating well, and she was her sleep was okay. And typically most women without hormones don't have great sleep. But when we did, I mean, what prompted her was vaginal dryness, and it was just, uncomfortable, and creams weren't working, and can you help me? And her commentary when she came back was like, wow, I didn't know that I could be even better than I was. Like, I was enjoying good health span, but now I'm finding that there's a crispness to it that was not there. And she will come in and say, I think I need a little tweaking, when she's like, I love my husband, but when I'm like looking at him and I want to snap at him, I know something's a little bit off. So she's very much in tune with her body. So again, we're telling anecdotes, but she's just the first that's popped into my head. But often individuals who are used to having a high level, if they're asking, then they're not functioning at the level that they're used to. And so providing them with a few more of those bricks allows them to build a stronger home, and they're pretty rewarded and happy about it. That makes
Cool.
sense.
Yeah, it does. Yeah, it does very much so.
So once you have the hormones balanced, what's next? What now do we focus on to live happy, healthy into 60s, 70s, and beyond?
Well, I mean, I don't do it in like, it's very rare that we do it like one thing and then we focus on another thing. It's usually a concert. I tell my patients I'm conducting an orchestra. Sometimes the violin section's not paying attention and we got to tweak that, perform. We have to practice a little bit more. But, health span or longevity or quality of life it's not just about hormone balancing. I mean, that just allows you to function more efficiently. But nutrition, we need to focus on nutrition. It's interesting when they talk about like the pillars of longevity. What I think one of the pillars that needs to be brought in, so I think there's going to be a seventh, there's always talking about six, is sense of purpose. As we get older, I'm hearing more from retirees, let it be men or women, where it's like, okay, I got my financial house in order, but nobody told me I needed to do something that gave me a sense of purpose. So purpose is huge. So some of what I help some of my patients to do, who, what are you doing for purpose? What are your connections like? Do you have good quality connections? Are you spiritual? Do you want to do meditation? Like, what is your spirituality? For somebody it's going to church, someone at synagogue, and somebody else it's skiing in the mountains. So we look at the other aspects that give people a full meaning, well, a full life that has a lot of facets that are meaningful, and it's not just simply physical health and hormone health.
Yeah,
So
I
when you
think it's
talk
really.
about, oh, sorry, Dr. Bob, go ahead.
I just want to say it's really a great point because it's really all about the mind, body, spirit connection. And to me, the way I'm hearing this conversation now is that there's a box that people live inside of, and when we're younger, the box is really big, and we almost never bump into the edges of the box, or when we do, we may not even know we're bumping into the edges of the box. But as we get older, the box is closing down, closing down, closing down. So our ability, so if we're eating poorly, we're not exercising, we're still not hitting the walls of the box. So when we provide hormones and tune everybody else's lifestyle up, the box can get bigger. That's the way I'm looking at it. The hormones allow the box to get bigger, and for those who are higher performance in terms of exercise and nutrition and relationships and social networks, they're able to operate way outside what the box would have restricted them without the hormones. That's the way I'm seeing it in a way.
Oh, that's a good visual. I would agree.
So
And
my
so,
question,
go ahead.
Dr. Josie, was that, the pillars that you focus on, are they driven by the patient, or are there specific things that you bring to their attention, or through this evaluation with the patient, you're getting to what those important things are, which you named off, purpose, spirituality, the physical side of it. Are there some key pillars that you focus in on, or do you really let the patient direct what those are?
I think for the most part, I tend to ask a lot of questions and listen. And I am, I can't, I'm, to be honest, I think I will allow the patient to drive those conversations, because I until I know them really well. Then once I know them really well, then I'm able to make suggestions. But in the beginning, I'm not it, without asking a lot of questions, I really don't know what that particular individual's um, full box or large box encompasses. So, and I learned a long time ago, don't make assumptions and don't say certain things because sometimes it's like, oh, I shouldn't have said that. So I do, for the most part, let patients drive the bus, so to speak. But if they're not, you know, eating appropriately and they come in and they say, I don't feel well, then I'm going to have to make suggestions because it's like, well, you can't possibly improve your health without, making better choices. And do you really think you should be drinking 2 to 3 glasses of wine every day? You think maybe that dulls your senses a little. So, I still approach it non-judgmentally because that's not helpful for anyone. But in the beginning, I let my patients sort of come to me with what's important for them to have a fulfilled full life.
But you sound like you do that, correct me if I'm wrong, you do that through active listening, as you said, through questioning, and you explore these areas of life with them and health with them. And then based upon what they tell you on that journey, you then kind of tailor their path forward. Is that correct?
Yes.
Let's go.
That's a good, yes, that's exactly what I do.
Let's see. Now I want to get back onto one point that you mentioned there that you talked about when you talk about their connections and their purpose. So unless they want to, or they're unfortunate, this doesn't happen to the woman in isolation. She's got a family, has a significant other, has a family. So in how can she either get them to listen, or what should we educate us as to what we should be asking about? So what's the best way that you can help this network really be supportive of that person? Really, and I don't even know supportive. I don't even want to act like it's it's what they used to think of pregnancy like a handicap. I don't want to come across like post-menopause, a handicap either. So let's not. I wrestle for a better word of support, but let's talk about how should we engage to help those women important to us achieve their health objectives, and how should they engage us?
Yeah, I mean, it's the listening, right? So when you've been with somebody a long time, there's this filter that goes over your ears and you stop listening because especially with, a lot of the women's symptoms are like vague. I'm fatigued, I didn't get a good sleep. I don't feel good. I know I'm not in the mood, or,
Mhm.
sometimes it's difficult to be supportive of your loved one because some of the symptoms are the same, whether it's a flu versus menopause versus pregnancy. Even I'm nauseous. So I think the best commentary is to take into consideration that we're all aging. Think about, your own physical challenges as we get older, and then, try your best to like ask questions. So you don't feel, go tell me a little bit about that. Is there something that I can do? Is there some kind of network is there something we could do together? I mean, having an opportunity to open up the discussion and have a discussion as opposed to either being dismissive or judgmental is important. But it's difficult in long-standing relationships to sort of really have an appreciation for what that person is going through, especially a different gender, because you have no idea how miserable a dry vagina is, unless you have one. It's like it's miserable, and you could sort of appreciate it, and like no lubrication in the world sometimes is enough. So it's things are painful. So being supportive, active listening, and then trying to direct help is what you can do as a partner. I hope that's where you were going. Go ahead, Bob.
Yeah, it's so important. You use the word, listening, active listening, so important. Because, and the other thing I want to say though is that it's also important to understand that the men, the partners, whoever the partners are, have to understand that it's not personal. And that's the thing, because when people have been together a long time, after a while, it seems like everything is personal, and it's not. It's just what the experience of the partner is. And so, if we can look at it like it's not personal, and we can listen, and we can talk about it, that's really great advice, Dr.
And I
Josie.
think so, and correct me if I'm wrong, because I might be making a gender slur here, but from my observation, sometimes male partners, they want to fix it.
Yeah,
And when they can't fix it, then they feel like they're
they failed.
they failed, and then they
Yeah,
get irritated by that.
yeah.
And so rather than be supportive, and it's not just about being personal, it's like, I can't fix this. So, and there is this level of sometimes you can't fix it. And,
And
and
also, women don't want to be fixed either. They want to be heard.
they
So
want to be.
So
Exactly.
men, remember that the women want to be heard and just listen. And that's why I was surprised when you said, "What can we do? How can I?" I guess you can ask, "How can I help?" That's probably okay for the women, but at least you're,
Well, I've learned over the years, Bob, when I catch myself. I won't tell you how long I've been married, Dr. Josie, but it's a long time because then you'll know my age. So I'll just say it's a long time. Um, but I have come now to ask. I said, do you want me just to listen, or do you want me to do something about this?
that's a good strategy.
But you're probably a direct kind of guy, and she knows that about you, so it's okay. But yeah, but so that active the asking the questions is still an act of listening because you're asking and then
Yeah,
allowing the person to open up.
absolutely. So important.
So we've kind of touched on what some of the signs might be. Let's look at it from the healthy side. What are some of the signs that you look for that your patients are on the right path?
So believe it or not, sometimes I don't need to look for the signs because I've had people literally come up to me and give me I'm tiny, I'm 5 feet tall when I lie, come up to me and give me a huge hug. And it's sort of like, what did I do? And they're like, oh my God, you've changed my life. So generally speaking, that's sort of the dramatic end of the spectrum. But again, I always tell women and everybody, give me a year because it takes that long for your body to trust that we're not going to take these hormones away. And what we start to see is I have individuals tell me they're sleeping better and they are recovering fast. When they go to the gym, they're like, wow, I notice I can do more weights or that weighted vest you told me to get. I have now got 14 pounds in there and I'm not at the 11 pound anymore. So I'm getting reports of improvement and then biochemically. I mean, I look at, when somebody says their brain is better and their folate used to be 4 and now it's over 20, I'm like, yeah, your brain has some B vitamins in there so it can function. So I still use some lab data and sometimes we get bone density testing that improves. So I use some scientific data, but for the most part, it's the reports that I get from individuals, like my body fat's less, and I wear my jeans, and
And also, the optimal thing for you, I would presume, is you lose clients because they don't need you anymore, right? They don't show when they show up, they're in trouble, right? So, or you're,
yeah, I mean, initially, some of my patients, when they come, and I'm like, well, it's in the beginning, it's expensive, but my goal is to see you once a year. So my goal is to get you out of my office. So unless of course we're doing hormone pellet therapy, and that's a whole other podcast. Um, that's a different interval. But my goal is really to see people annually, because if they are, it means they're thriving and they don't need me, but I do need to examine them and make sure that nothing shows up. But that's my goal. So yes, but then hopefully they'll refer their friends.
so I admire you for having that attitude. Yeah, everybody should have that attitude.
Mhm. But yeah, yeah. I'm surprised you're not going to get into questions about, what advice do I have for other doctors?
Actually, I did have
Well,
that
since you
question.
opened that door for us, what? Go. If you want to comment on that, Dr. Josie, go right ahead.
Yeah, well, let
Okay,
me preface that
Rex
that
got a
not
finger up.
yeah, not everyone is an expert like you, and everyone means well. We have all these wonderful, primary care providers that are they mean well, they're doing, their very best. What additional support would you say they could provide?
Well, I think that and I have somebody in my neighborhood who refers to me, and There was one time where I did something and he sort of raised an eyebrow, and I'm like, would you like the literature on X? And then he like turned around and read it and he goes, wow, I had no idea. Thank you so much. And thank you. Initially it was like, what the hell are you doing with my patient? And then it was, thank you for taking such good care of my patient. I always send them back because I'm not in the business of, I'm more cooperative. And that's my goal is I want to cooperate with the locals. And I recognize not everybody's passionate about hormone health, and that's okay. But it is helpful for doctors not to be dismissive. It's really, and it's hard. Like I used to be in that world where you had 6 minutes with a patient and you look at labs, they're fine. And you're like, you're fine. Like, what do you want from me? You're fine. I can't fix it. But if someone, comes to a physician's office and they feel that they still have, they're not first of all, active listen, but if they feel they cannot solve the issue, then find their network in their community and make sure they know who's an expert in what, and feel free to call that person up, learn. I'm happy to talk to any doctor, and especially since I'll say I will send them back. Like, I am not interested in taking your patient from you. I don't do internal medicine. You can do all of that work, but listen and refer if you aren't comfortable, but know that there are experts out there and it's not so scary anymore.
So I used to run a home care agency for the elderly. So they have geriatricians. They would focus on aging in general. So they would do things. I often felt, would support people and took care of people predominantly between the ages of 79 and 90, usually about 85. But I often felt they gave up on them too soon and said, this is where you're at. So where I'm going with that comment is how prevalent, or is it prevalent, that whether it's people, physicians in general, or general public just kind of says, I don't have, this is just the way things are. Don't fight it. Aside from, bone, I think every physician out there looks at the bone loss and the bone density. But aside from that, do you think there's too much just acceptance of where things are at, of post-menopause?
Well, I think that based on, women wanting this information and women wanting to sign up for workshops, and there's this desire for information. I think that because, it's put into ChatGPT, what's the latest, hot topic, and for women, it's this, it's we have an aging population. And I think that, everybody wants to play pickleball. Everybody wants to do things and be as vibrant as they can, and they get frustrated if they're not able to perform because they're aging. So I think, I don't think it's ever good enough to just say it's fine, because you could live to 120. And if I have bad quality of life, I want to be gone. But if I'm going to live to 120, I want to have my brain, I want to have mobility, I want to have my health, I want to have my community. So, I would say it's never fine to just say that I'm going to give up on you, because you have to really look at the individual. And there are people who give up and they don't want to be here anymore, and we kind of like string them along too long. So that's a whole other conversation. But I would say that anybody who wants vibrancy and a great quality of life deserves to be heard, and that they deserve to have whatever health they can get, and whatever that means, whether it means hormones or not. Deb?
I don't know if you even have any perspective on this, but I'm hoping you have some. Are Because I don't think you'll run into these women. Are there women who are out there that they're menopausal, they're not taking hormones, and their bodies are functioning, more or less the way they want them to, in the various areas that we've been speaking about? Is that like feasible? And what percentage of women do you think fit in that category? If you have any thoughts about that at all?
I wouldn't know the percentage because they don't show up in the office. I do
That's what I
think
thought.
that, yeah, I do think that what's interesting is that there's some ethnic variation where there's certain cultures that, women are miserable, but they're afraid of hormones. It's not culturally appropriate to be hormone augmented. They are afraid of being too thin because thin equals poverty, because rich people are heavier, thin, skinny people are out in the field. So there, I mean, I'm talking some
Yeah.
conversations I've had. So I don't know the answer to your question, Bob, because they don't necessarily come into my office. It's probably a bigger percentage than I would ever see. But I think what's a bigger hurdle, and I don't know how to reach them, is some of these women who've got some beliefs that are so entrenched in their cultural beliefs that they're willing to suffer. And
Yeah.
and being the healthcare provider that I am, I want to help. And
Yeah.
so that's
What,
probably a big chunk
yeah.
of, at least North America.
So when you look at women in menopause, their normal labs, and their labs, sorry, not normal, their labs. Do you have any idea what percentage show like super low hormone levels and need augmentation, or is that a percentage that's known?
I mean, if they're postmenopausal, most of them aren't going to have any estrogen. And if they do, they're usually obese and it's fat derived, which isn't necessarily healthy because that puts them at risk for other things. There are some women who, they have low levels of testosterone, and it's sort of like, no wonder they didn't have any menopause symptoms when they went through menopause. And, I've had them where they're like, I'm good with this, or my libido. I mean, a big one is DHEA. I mean, DHEA is low universally in almost everybody I see, and a lot of that has to do with just bad sleep. So, sometimes fixing the sleep restores it. Sometimes I do have to intervene, but you know, we don't, I mean, that's why hormones optimization is so challenging, because we don't sit there and put a probe in every 17-year-old male and female and monitor them for a month and say, at their most vibrant age, this is what their hormones did over a 30-day period of time. This is my goal hormone level. We don't do that. So, and for who knows, I'm unfortunately seeing a lot more low hormones in younger ages for a lot of other reasons. And replacing young people who are still of reproductive age is challenging.
So
But
for
it's
women
working.
today listening, Dr. Josie, that are feeling, tired, brain fog, fatigue, just not like themselves, what can they do today to start to reclaim their vitality?
Well, the first thing is know that it's not normal or it's not okay, and they're not fine. I don't care what their blood tests say, they're not fine because they have symptoms. So, finding ways to get better sleep is helpful. So if they, aren't in a community where they can readily access somebody like me, look at their nutrition, look at their working out, see if there's some supplements they can, take, but essentially they need to really reach out and find a provider who's willing to listen to them and intervene, because clearly if they have those symptoms, they need intervention, or they would benefit from intervention.
Right.
All right, and then I just want to reiterate, because like we keep talking hormones, and that's good because that's important. Like, so that's the mixture, that's the catalyst, that's what enables things. But I don't want people to, because we've talked and multiple times, and so I know where your mindset's at, and it's come through here. I don't want people to walk away saying Dr. Josie's just a drug pusher. So take a moment, if you would, and reiterate the pillars that you look at and that you do active listening for, in addition to hormones, to help postmenopausal women create a thriving life, Dr. Josie.
Thank you for that. I did say at the beginning, hormones aren't for everyone. But one of the nutrition is important, and that is specific to the individual. I was born in the Mediterranean. I do well with the Mediterranean diet. So specific nutrition for your genetics is something I believe in. Proper sleeping, so having the best quality sleep, so sleep hygiene, making sure that you have a good sleep hygiene process is important. Being metabolically healthy, sometimes that's in your control, sometimes it's not, but look at your community, have as much community out, connections as possible, because that's really, really important for health span. So whether it doesn't matter what you join, make sure that you have a supportive community around you. So we talked about physical activity. We talked about, mental health. It's it's very, very important to be as happy as you possibly can. And if you're not feeling like you have the best mental health, then that's something that there's help out there, and don't ignore it, because mental health is important. I've alluded to a different pillar for me is just a sense of purpose. You need to get up in the morning and feel like I want to get out of bed because I have a place in the world and I have a purpose, and that's really important. And intimate intimacy is also important. And we're running out of time, but I think those are the key ones for me.
And the one last thing I want to mention is stress.
Stress management, yes.
Yeah,
And
that's really critical too. Yeah.
that's part of mental health. So, but yes, thank you. Stress management, mindfulness, all of that is really important.
Excellent.
Fantastic.
Well, is there anything else that you really felt like we should cover in this segment that we didn't get to yet?
Me? Yeah, is
Yeah.
that question for me?
Yes.
I think that, yeah, I'm not a drug pusher, but I think there is some unnecessary fear out there. And so I just want, my last words are get educated, because, there is more information out there, and it really is critical to be your own advocate, especially now. You really need to be your own personal health advocate.
Yeah. Oh, excellent. Well, a huge thank you to you, Dr. Josie. Thanks so much for coming on with us again. And I'm absolutely going to have you back, because
Thank
you
you.
are just a wealth of knowledge for us, and we're excited to be associated with you. And I want to remind all of our listeners that if you haven't yet, please join the WellWaveNOW Healthcare Disruptors Facebook group. We'll leave a link for that in the show notes. And always, until next time, stay curious, stay empowered, and remember, wellness, it's in you.